can't be done.
Okay, moving on to anesthetic agents. Anesthetics. When we're talking about anesthetics, we're talking about no sensation. Classified as general anesthetic, reversible unconsciousness, or local anesthetic, which is reversible regional loss of sensation while conscious. Today we're going to talk about general anesthetics overall. Anesthetics cause loss of pain perception due to loss of consciousness, not simply by blockage of pain sensation. So when we're talking about anesthetics, is there analgesia? The answer is no, or at least not necessarily. So just because we're getting rid of consciousness doesn't mean that they can't feel pain either during the procedure or, of course, immediately after waking up. Remember pain wind-up, that whole process of pain modulation and then pain perception. The modulation and eventually perception, but modulation is still occurring during anesthetic. So without the analgesia to block those pain sensations to even getting to the point of modulation, modulation will continue to happen. And then, of course, as soon as the animal wakes up from anesthesia, that wind-up is occurring because the perception is occurring. So it shifts over from modulation to perception as soon as they wake up. So that's the theory, that animals who don't have adequate pain management on board, of course, during anesthesia, during a surgery, then they wake up just extremely overexcited and very, very painful. So a wake up without pain medication, so without ideal or balanced analgesia during a surgery, boom goes the dynamite. So bite central. Be very, very careful. A very painful animal who is entirely wound up. And remember, always, 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 it's easier to prevent pain and to tackle it at different areas of the whole anesthetic process than it is to treat pain wind-up. Okay, so animals, of course, who wake up from a surgery or from a painful procedure while they're under general anesthetic, if they haven't had enough pain management on board, they can wake up just totally freaking out with pain and ready to bite, of course. So anesthetics, again, they mean no sensation. So what about the concept of anesthetic awareness? It's not part of the lecture in full. We don't have to know too much about it. It's just a point of question. In humans, they find that, I think it was 1 or 2 out of 1,000 surgeries in people end up that people actually remember the process of the surgery. So even though they're under anesthetic, there's no sensation, their eyes could be closed, they might not be seeing what's going on, they're hearing it, and they're feeling it. Not the pain, but they're feeling the pressures and whatnot changing in their body as surgery is happening. So this is a really traumatic event for people when it happens, and it's not terribly uncommon. I just always wonder if it happens to animals, that's all. And I don't know that we would ever be able to prove this because they're not feeling pain, their heart rate won't necessarily increase. It's hard to regulate and to actually identify whether or not they're able to perceive what's going on. So it's just interesting, just a point of conversation, because I do wonder if it happens to animals the way it happens to people. So we'll talk about injectable anesthetics to start with. We're going to start our conversation with barbiturates. Barbiturates generally end in the "tol" suffix, so the end of the word is tol. Examples are phenobarbital, pentobarbital, and methotrexate. Injectable anesthetic, these are, and they're derived from barbituric acid. They are central nervous system depressants, and typically they're used more historically than they are today. So essentially, in this category of barbiturates, we have different classifications of barbiturates. So we have ultra-short-acting barbiturates, and that examples would be thiopental is ultra-short-acting. Typically, these are just used for anesthetic induction, and then they're taken over with gas anesthetic. Methotrexate is also ultra-short-acting, so that could be a matter of minutes. We have short-acting, which is pentobarbital, but I'll talk about pentobarbital because we don't even use it for anesthetic anymore at all. And then we have long-acting, which is phenobarbital, which is actually used more as a maintenance seizure medication than it is as any sort of anesthetic. So we'll talk about them a fair bit. We really don't even use barbiturates much anymore at all, but we use two of them often, but not for anesthetic. So thiopental and methotrexate, I think thiopental you can still get in Canada, and it's a solute, that you have to add water to, sterile water, to create a solution. I don't think we get methotrexate. I could be wrong, but I don't think we get methotrexate. In my 13 years, I've never seen methotrexate. Thiopental, I'm pretty sure it's on its way out. In the States, they can't even get thiopental anymore. So those two are really short acting, matter of minutes. Phenobarbital is long acting, and typically, again, going back, that's the one that we use as a seizure medication, so long-term inhibition of seizures. And then the short and the ultra short acting, they're very quick to cross the blood-brain barrier. So what that means is that we get a very quick, almost instant effect with these guys. Likewise, if they're short and ultra short acting, they also get circulated and start passing out of the blood-brain, out of the brain as well. And therefore we start losing their effect. So barbiturates, if we're looking at the one that we use a lot of the time, especially in emergency medicine where I typically work, is of course pentobarbital. This is, I like to call it the extra long lasting, because in fact we typically use it as a euthanasia medium. So it's an agent that of course can cause anesthetic, and we technically could use it as an anesthetic in very small doses, but more often than not, because it's a potent anesthetic, we tend to use it as a euthanasia drug, which is really great if we're looking at humane options for euthanasia, because it's an intravenous injection and it literally puts the animal to sleep. So it anesthetizes them, and then it's an overdose of an anesthetic. So then their heart stops and their respirations stop. So in the way of choices around euthanasia, this is a very, very humane method for euthanasia. So their mechanism of action, they enhance the action of inhibitory neurotransmitters, so they're preventing some of these synapses from firing, and then they're suppressing the action of excitatory neurotransmitters, so they're preventing that excitation. GABA A receptors, so essentially they bind on the terminal boutons of postsynaptic neurons to potentiate the effects of GABA. So these are another GABA central receptor. So they really, really increase the effect of GABA. And essentially they're allowing those negative chloride ions, I'll just go back, so barbiturates bind to the GABA A receptors. When they do this, they really increase the effect of GABA itself. When this happens, when this GABA is really affected and they potentiate the effect of GABA, then this allows the chlorides, the negative chloride molecules, to come in, the chloride ions to come into the cell. When they come into the cell, they create a negative charge on the inside of the cell as compared to outside of the cell, and that is harder for that cell to activate. So it's harder for that transmitter to fire when they have a negative charge on the inside. And that's where we get into action potentials. So that's essentially what's happening. The chloride is coming in through the channels, and in the end, it inhibits transmission. It inhibits firing of that neuron. They also block AMPA receptor, which is sensitive to glutamate, which is responsible for excitation. So essentially, they block the AMPA receptor, which is a receptor to create all this excitation in the body. So through the two, binding to GABA A receptors and reducing the chances that those GABA receptors will fire, and then blocking the AMPA or the excitatory receptors, then we start to get this overall effect of central nervous system depression, which is great for general anesthesia, but we have to be very cautious because they're quite significant central nervous system depressants. Benefits: they can be fast-acting, ultra-short anesthetic agent, and they, of course, can provide humane euthanasia. Drawbacks: they're really severe respiratory and cardiovascular depressant. They're fat-soluble, so they're not ideal for thin dogs. Essentially, they redistribute, so they cross the blood-brain barrier, they get into circulation, and they redistribute to fat very easily. and then they slowly leak back out into our body for excretion. So it's like they get absorbed to the brain, and then they go into the fat for redistribution, and then they slowly get circulated back out for excretion. So that being said, I'll just skip the third point and skip to the next one here. They're very slowly metabolized, and the excretion is very slow as well, because they do take time to go into the fat, get redistributed through the fat, and then they make their way back out through the blood and through excretion. And you can get potentially hangover effect in a lot of animals because the drug stays in the fat for too long. Okay, things to keep in mind. Also, if these drugs go perivascular, so if they enter the body any way other than through the vein, they can cause really severe sloughing of the skin. So that means that the tissue essentially necroses and falls off. Really, really painful. If we're using a barbiturate like a thiopental and we get it perivascular, we have to treat it right away. So we typically will apply a warm compress, or we'll sometimes inject saline under the skin to help redistribute that medication so that it's not just sitting there, because it can really, really burn the skin, and of course the skin can eventually fall off. So we're going to carry on with some drawbacks, because of course this is all why the drugs are no longer used in most cases. We always, always, always avoid barbiturate use in sighthounds and really thin animals. It's very easy to overdose in sighthounds and skinny animals because it stays in circulation longer. Because there's little fat or no fat, there's always fat. So when there's little fat, there isn't an opportunity for the drug to go out and redistribute in the fat. So instead it goes directly into circulation. So they get sort of heavy hits from it instead of it being redistributed through the fat. There's a lot of differences between patients for recovery based on body type, age, health. Apnea, so lack of breathing, happens after the initial bolus, and it can be quite severe. Obese patients, we always want to give a lower dose to, because it can accumulate in the fat. Essentially, the dosages can add up over time. So you have to be very cautious with obese patients. We have to be very cautious with skinny patients. And long-term use, it can cause major liver damage. Phenobarbital has an increased metabolism of other drugs as well. So when animals are on phenobarbital for a long period of time because of seizure interactions or occurrence of seizures, we always have to check their liver values at least every year, if not every 6 months, to make sure that we're not getting liver damage because of the phenobarbital. And then we also have to watch out if they're given other medications like antibiotics or any other medication. There's always potential that phenobarbital can increase the metabolism of the other drugs, so they may in fact need a higher frequency or a higher dose of other drugs. Kind of interesting. So putting these all together, they're really severe CNS depressants, really severe cardiac respiratory depressants. They're not great in skinny animals. They're not great in fat animals. They're not great in the really young. They're not great in the really old. A lot of issues, and of course long-term use can cause liver damage. So typically we're not using barbiturates anymore so much for general anesthetic, and eventually we probably won't even teach you about them when it comes to general anesthetic. There is a small chance you might still use thiopental. I'm pretty sure I've heard of some students using it while on placement. So that's why you're still learning about it. So class, they are barbiturates, and we're talking about general anesthesia properties. Trade names for thiopental, we've got pentothal. Methohexatol, we've got brevital. Phenobarbital, we've got phenoliptal or luminol. Luminol, I believe, is the human form. And pentobarbital, we have euthanol and euthansol. Modes of action, they bind to GABA A receptors, and they also block the AMPA receptors, both of which they're preventing excitation of those transmitters. Positive effects can be used as an ultra-short acting anesthetic, also can provide humane euthanasia. And then, of course, the side effects, just a couple: respiratory and cardiovascular depression, not ideal for thin dogs or sighthounds, sloughing of skin if perivascular, slow excretion by liver, hangover effect in fat, apnea, liver damage and long-term use, and of course drug interactions with long-term use as well. If we are administering this, it's IV only, and then if we're talking about phenobarbital, we're normally talking about phenobarbital in regard to its seizure inhibition, so we'll talk about that again when it comes to anticonvulsants. But if we are talking about phenobarbital, then we can give an oral version, and an intravenous version. So for all these reasons, just looking at the side effects, this is not a drug that we want to see much in the clinics anymore because there are better options. But the one that came after sort of the barbiturates to replace the barbiturates is propofol. Propofol is a short-acting injectable anesthetic. Dogs, it lasts about 20 minutes. Cats, about 30 minutes. It's unrelated in action to all other anesthetics because it actually directly stimulates GABA A receptor. So instead of just attaching to the receptor to enhance the effect of GABA on the receptor, it's actually stimulating GABA A receptors. So it's, again, having the same mechanism of action in that it allows for the chloride ions to enter the neuron and thus exhibits a negative charge, and that in turn makes it more unlikely to fire when it has the negative charge. And then, of course, this is a suppressant effect, so it's a suppression of neuronal activity in the brain, resulting in sedation or anesthesia. So it works similarly to a lot of the other drugs. I believe it was benzodiazepines and then, of course, the barbiturates, but it directly stimulates GABA A receptor instead of enhancing the effects of GABA on the receptor. So original propofol solutions, just important to point out about them. So you can see it's a white milky solution and it's for short-acting anesthesia. The original solutions were made dissolved. It was the medication itself dissolved in egg lecithin and soybean oil, and thus had to be discarded after about 24 hours due to the potential for contamination. So the old propofol had a really high propensity for bacterial contamination, which of course we don't want to happen because then we'd be giving bacteria intravenously, which would be really crummy. So I think most of the new propofols now last up to 28 days, and you don't have to refrigerate them necessarily after opening. A lot of times we still do, we're creatures of habit, but a lot of the formulations have been changed to take away that huge risk of contamination within the multi-use vial. Just also to point out too, mechanism of action, propofol also inhibits the NMDA, which is, we'll talk about more about that receptor when we talk about dissociative anesthetics. Propofol, if you recall from the news, unfortunately was what Michael Jackson used to fall asleep and of course died because of that. And if you've ever had a short procedure done at the hospital where they give you IV, so intravenous anesthetic, most often it's propofol. One thing to note too, if you've ever had propofol administered to you, it's very quick to act, and of course it's short acting, doesn't last for very long, and a lot of people report a burning sensation as it enters into the vein. It's something to keep in mind when we're administering to animals, that they may draw their leg back if we're administering propofol. It only lasts about 10 seconds because of course they fall asleep within that 10 seconds, but it is something to be aware of. If you have a high-strung cat and you're administering propofol, you might want to just be aware of your restraint and be able to restrain them if they decide to start pulling their paw back or flicking their leg. So sadly, because of propofol, we had to say goodbye to dear Michael Jackson. So propofol provides little to no analgesic properties. It's important to know that because of course we want to add in analgesics if we are using or creating a painful situation. We give it as an IV bolus that we titrate to effect. So we give a large dose, titrated to effect, and just depending on the procedure, if we need to intubate and then put them onto gas anesthetic, then we'll just titrate to the point where they don't have a lot of jaw tone, and then of course place our endotracheal tube. Plus or minus that preservative, so check your brand, check the bottle. That's what I was talking about, the egg in it. And it decreases arterial blood pressure and increases vasodilation. So this results in a pretty significant hypotension, so low blood pressure. For this reason, we're going to have caution using it with patients who are already hypovolemic. And cats, so this is a phenotype of medication. Cats don't metabolize it very well, and then of course because of that they get these Heinz bodies on their blood cells. So that's something that you guys probably either have or will see when it comes to clinical pathology. But the propofol, after using propofol on cats, especially chronically on cats, you'll start to see Heinz bodies develop on their blood cells. One downfall of propofol that I find, I actually don't like propofol anymore because of this. It has significant apnea upon bolus. So typically it's, up to a minute after the initial bolus, but I've had it last minutes, where the animal's not breathing on their own at all. And it's really hard to stimulate them to breathe. So just be aware of that can happen with propofol. The speed of administration of propofol is directly related to the amount of apnea. So if we give propofol very, very fast, then we're going to get a high level of apnea, which is really not ideal. So we want to give propofol impossibly slow, like we're really giving it impossibly slow, so that the animal slowly is induced under anesthesia, and we're reducing the risks or the chances of having that apnea set in. I don't know if you can hear my cat snoring in the background. That's what that is. Okay, propofol is fairly safe in most animals, and it's very in very quickly, and it doesn't last very long. It's a really good anesthetic agent to induce an animal under anesthetic and then transfer them. So the class is general anesthetic. Trade names, we have Diprivan, Propofol. Mode of action, it directly stimulates the GABA A receptors, which creates a lack of firing of that GABA A neuron, the one that's affected by GABA A. Positive effects, it's short-acting anesthetic. It's generally safe for most animals. It's quickly metabolized and excreted, so no hangover effect with propofol. It's safe with renal and hepatic insufficiency, which is why we often use it in sick animals if we need to do an anesthetic, and it can be given to reduce seizure activity. Side effects, it's very short-acting, so we have to keep in mind we don't have a lot of time with propofol. We give them the propofol, and typically we intubate to put them on gas anesthetic. There's an immediate apnea that's directly related to the speed at which the propofol is given. There's pretty much no analgesic property, can cause hypotension, plus or minus, it can actually cause seizures too. So it's kind of a weird one, is that it can inhibit seizures, but then there were a couple studies that were identified that potential that it could also increase the risk of seizures. It's kind of strange. So histamine release here, histamine release was a finding at one point, but recent human studies have identified that the incidence of histamine release is similar with propofol as with other anesthetic agents. It's something you might come across in the literature. Of course, if there's histamine release, we always worry about a systemic allergic reaction. But if you come across that, the most recent update that I got is that, of course, histamine release with propofol is essentially the same as giving any anesthetic drug. And it's that body's own systemic reaction to that entering into the body. The way we give it is intravenously, slowly, and we also can give it by constant rate of effusion as well. Alfaxalone. Alfaxalone we'll talk about. It's an interesting one. It's a neuroactive steroid derived from progesterone. So it's interesting in that it's a steroid, but it has similar GABA A effects as benzodiazepines. So it enhances the effect of GABA on GABA A receptors. And of course, again, once GABA is once GABA is affecting GABA A receptor, then the negative chloride ions enter into the cell, causes the negative charge of the cell, and it's less likely. So it's a short-acting anesthetic. Let's get back to the important stuff. It's a short-acting anesthetic. It lasts about 9 minutes in dogs and 15 minutes in cats. It does have a level of muscle relaxation, not 100%, but it has a level of muscle relaxation, has a wide safety margin, and it's rapidly eliminated. I'm just going to throw it out there. You'll notice that there are hearts all over my PowerPoint for Alfaxalone. I love Alfaxalone. It's my favorite anesthetic induction agent, and I'll tell you why in a minute. So Alfaxalone, this is part of why. Alfaxalone is safe to use with almost all pre-anesthetic agents and non-steroidal anti-inflammatory drugs. The absence of respiratory depression, so unlike propofol, Alfaxin, you still titrate, you still go slowly, but Alfaxin, I've noticed I don't get half the apnea that I do when I use propofol on animals. So that respiratory depression in the immediate use of Alfaxalone is not as severe as that of propofol. So essentially, it has all the great qualities of propofol, but it doesn't have the apnea, which is really great when you have sort of a higher risk patient that you're trying to anesthetize. It's better, so better metabolized, higher level of safety, and it's actually on label for cats. A lot of our general anesthetics are not on label for cats. Do you want to know another reason why I love Alfaxalone? Because, speaking of cats, I love cats, but you know that. More importantly, Alfaxalone can be given intramuscularly. So we can give it IV as a general anesthetic for immediate use, but we can also give it intramuscularly in a low dose as a sedative and in a high dose as a general anesthetic. So it's really great for those grumpy cats that all you can do is pin them with a towel, give them an injection, and then let them chill. Really, really great for feral cats or for those untouchable cats. So I really like Alfaxalone. And then you can use Alfaxalone intramuscularly and then top them up intravenously. Once they're, of course, sedate, you can get an IV catheter in, blah, 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 blah. So it's really great for that reason. So Alfaxalone class is general anesthetic. It can also be used as a sedative. Trade names are Alfaxin. Mode of action, it enhances the effect of GABA on GABA A receptors. Positive effects, it's short-acting anesthetic, safe with most drugs, safe for most animals, on label for cats, can be given intramuscularly, way less respiratory depression than propofol. Great recoveries. I love it. I love it, I love it, I love it. And a little note about recoveries. So again, if we're comparing propofol to Alfaxalone, I really do find a significant difference in straightforward propofol recoveries and straightforward Alfaxalone recoveries. The recovery is always influenced by whatever we're mixing in with the pre-medication. So if we're using hydro, midazolam, or if we're using hydro and ACE, whatever we might be using, because that's going to give that sort of continuous effect throughout, and they'll have a smoother recovery. But for those cases where we're just using an induction agent, maybe without a pre-med for whatever reason, like porcupine quills sometimes, I find Alfaxalone is a much smoother recovery than propofol. Side effects, short-acting, so if you're looking for a long time or long anesthetic, this is not ideal for continuous use. The other thing I guess I should put up here is side effects. It's not a side effect, but a downfall is that it is a little bit more expensive than propofol. And that's quite often why most clinics are still using propofol as compared to Alfaxalone. We can give it intravenously or intramuscularly. It is not a controlled drug. Neither is propofol. Propofol is also not a controlled drug, which is good to know. And I just love it. I love Alfaxalone. Okay, so now we'll talk about dissociative anesthetics. These are an interesting class of drugs. We're generally just going to be talking about ketamine. So the dissociative anesthetic is where the animal dissociates from its body. So the animal is separated from its body, kind of like an out-of-body experience. The mechanism of action for ketamine is it disrupts the NMDA channel activity, so it's an NMDA antagonist, which results in catalepsy. So catalepsy is where they cannot move. So they can feel stimuli, but they can't respond to stimuli. So going back, by blocking stimuli on the body, it creates that dissociative effect whereby they're aware, but the brain and the body are two separate entities. They're not working together. And that essentially is catalepsy. Unfortunately, this drug, of course, has a high street value. It's special K on the street, so it's definitely a controlled drug. And it also has a high likelihood of addiction because it's not necessarily as physically addicting or chemically addicting as morphine, but it is that sort of mental addiction to it, whereby it produces really great feelings in the body and people want it more and more. Okay? So ketamine, it's a dissociative anesthetic. So it's a central sympathetic nervous system activation. It causes central constriction. So for that reason, we've got vasoconstriction. Increased heart rate, increased blood pressure, and it causes cardiac disease, we're not going to give them ketamine. If they're tachycardic, like a fast heart rate, we're not going to give them ketamine, because if we are increasing the workload on the heart, if they already have cardiac disease, if they already have a fast heart rate, we don't need to worsen that by giving them ketamine. Could this be a good thing? Not the cardiac disease and whatnot, but the central sympathetic nervous system activation, where we get vasoconstriction, increased heart rate, increased blood pressure, increased workload on the heart, at least the first three there, could it ever be a good thing? It can definitely be a good thing. So we use this medication, we often use it as an induction agent with Valium, so we create ketamine-Valium combination, 50-50. I use this a lot when we do field medicine and we do spay-neuter clinics out in the middle of nowhere. So we'll use a pretty sedating pre-medication. We often use dexdomitor and hydro mixed. So we've got an alpha-2 agonist, and then we've got an opioid mixed together. So we know that the alpha-2 agonist causes bradycardia. So essentially, with that, we start to get some pretty worrisome heart rates. So the lowest heart rates I've ever heard are typically when we're using high-dose alpha-2 agonists, and I might get a heart rate down to 30 on a dog. But I'm not going to jump and give the reversal for the alpha-2 because I know that I'm administering ketamine and Valium together for the induction agent. And as soon as I administer that ketamine and Valium together, the ketamine kicks in, the central sympathetic nervous system is activated, and suddenly these animals have a low normal heart rate. So instead of 30, it might go up to 50, 55, and their blood pressure increases. So everything that I was worried about with the animals who are on alpha-2s is somewhat corrected when we administer ketamine. So it's kind of like a magic drug in that way. It doesn't reverse those effects, so it doesn't reverse the sedation of the alpha-2. It just supports the central sympathetic nervous system. So that's important because it can be a really negative thing for some animals, but it can also be very positive. Cats with renal disease have caution. It's metabolized through the kidneys in cats and through the liver in dogs. So either renal disease in cats, or if a cat has a urinary obstruction, there's always caution given to the use of using ketamine Valium to get that cat down, just because they already have so much workload on their kidneys trying to process the urine that's backed up. And then dogs with liver disease, of course, caution because it is metabolized through the liver in dogs. Ketamine is great because it also has an analgesic effect. So the NDMA receptor plus the stimulation of mu and kappa receptors is great for superficial, it's great for peripheral tissue analgesia. So it's great for superficial skin or superficial surgeries, but when it comes to abdominal surgery, it's not quite as ideal as an independent analgesia. It can definitely complement your analgesic protocol. A lot of time we'll do ketamine as a constant rate of infusion, so as a CRI, to maintain a certain level of pain management throughout. However, so again, just going back to that, really important that this does work really well in regard to wind-up prevention. The antagonist activity on the NMDA receptors play a role. They seem to play a role in the prevention of wind-up in the spinal cord. So the NMDA receptor activation is part of the wind-up pathway. By blocking this, it prevents it from reaching the brain. So the ketamine can actually disrupt that whole pain wind-up pathway, which is really, really great. And that's really great in severe surgeries. So even if it's an abdominal surgery, it's great to have ketamine on board just to carry them through and prevent that wind-up. So with ketamine, we can get changes to breathing patterns. So we may not get respiratory depression, but it causes changes to the actual pattern. So the animals will take slow, long breaths, they'll hold their breath, and then quickly release. That's called apneustic breathing pattern. So even throughout this breathing pattern, we still get normal carbon dioxide levels, so blood carbon dioxide levels. Most regulatory reflexes are maintained. The swallowing reflex, the breathing change in response to CO2 levels in the blood, and the cough response, those all maintain themselves if we've given an animal ketamine, so beware of that. There's a general lack of muscle relaxation and actually increased muscle rigidity. So quite often we'll be giving this with something like diazepam, so benzodiazepine to assist with that muscle relaxation. Because if we just give ketamine on its own, we have to be cautious of what we're using it for. If we need to pose that animal for radiographs and they only have ketamine on board, they might be too rigid in their legs and their muscles. If we have to perform any sort of surgery whereby we're manipulating their limbs or we need to stretch their limbs out, then ketamine alone is going to cause too much rigidity in their limbs and in their muscles. So always keep that in mind. The eyes do stay open. Also important to note, that's up to us. We definitely need to be lubricating those eyes often through anesthesia, because when the eyes stay open, they don't get lubricated, and they're at really high risk of getting corneal ulcers. Okay, really, really delicate membrane that covers the eye can easily get ulcerated. Nice little benefit too about ketamine is well absorbed through mucous membranes. So in those fractious cats, we can give ketamine sprayed in their mouth, and it will get nicely absorbed through their cheek pouches and through their tongue. So really, really great for that. And then we have this other one called Kitty Magic, which is a really great sedative for cats. So Kitty Magic is dexdomitor, so that's alpha-2 agonist, ketamine, which is a dissociative anesthetic, and torbagesic, which is an opioid. And the three of them combined create this, it's really, really severe sedation, borderline general anesthetic. And we give that either sub-Q or intramuscularly. And you can have an angry cat like this guy. You give Kitty Magic, and not 10 minutes later, the cat is totally flat out. Wonderful to work with. Every clinic should keep a little vial of Kitty Magic. So then looking at our chart, ketamine, the class is dissociative anesthetic. Trade names, we have Vetalar, it's called Ketalar in humans, Ketaset or Ketaflow. It's an NMDA antagonist. It has analgesic properties, maintains reflexes, can prevent modulation of wind-up through the spinal cord, excellent complementary drug to anesthesia and analgesia, and it does not cause hypotension. Side effects, it's metabolized in the kidneys in cats, in the liver in dogs. It increases cardiac workload, can cause muscle rigidity, potential for corneal ulcers because their eyes stay open, and of course there's a potential for abuse and addiction in humans. It is a controlled drug, so we have to record its usage, and we can give ketamine IV, subcutaneously, intramuscularly, and transmucosally. So just going back to this, ketamine generally we don't often give on its own. The only time we might give ketamine on its own is to those feral cats who get it squirted in their mucous membranes. Otherwise, typically we're complementing ketamine either with a sedative or an opioid or both, like Kitty Magic, or with a benzodiazepine, like you can do ketamine midazolam, ketamine Valium. Those 50-50 can create nice anesthesia, general anesthesia. All right, anesthetic gases, a whole class of their own. So anesthetics, these are inhalant anesthetics. They promote general anesthesia after injectable induction. So quite often we try not to only use inhalant anesthetic. It's not as well balanced if we just try to use inhalant anesthetic. So if we mask a patient down or put them in a chamber. So instead we like to give an injection of intravenous anesthetic and then complement it with inhalant anesthetic. It's inhaled, of course, with oxygen and absorbed through the alveoli to enter the brain, which ends up creating unconsciousness. The goal is to administer the tiniest amount possible of a very dangerous substance. So it's really important for us to know, and we'll talk about this a lot, that anesthetic gases are very dangerous. Okay, we try to use the tiniest amount possible to maintain anesthetic in each patient. Each patient is different, so each patient will take different amounts of anesthetic. And we'll talk about the uniqueness of inhalant anesthetics and why it's a concern for us in a couple minutes. So balanced anesthesia via gas, that's a whole chapter of how to maintain and regulate gas anesthetic, so we're only going to touch on it quite lightly. It's important to note that in general, inhalant anesthetics are not analgesics, so they do not provide analgesic qualities. And all of them are cardiovascular and respiratory depressants. So really important to note, all of them are cardiovascular and respiratory depressants. So again, going back to that, we want to administer the tiniest amount possible of a very dangerous subject or substance. Some interesting facts, interesting and a little bit concerning facts, is that anesthetic gases, they technically don't know how they act on the body. Okay, so keep that in mind. They technically don't know how they're metabolized in the body. And more that we don't know why about is that anesthetic gases can affect plants that respond to touch. So venous flytraps can get anesthetized. They work very well on birds, very well on reptiles. So it's pretty crazy that anesthetic gases can work on all these different types of plants and animals. Very strange. And they don't in the body. It's very weird. It's something to keep in mind because we really gases. That's my thought. Because they don't know exactly how they work, we should keep our exposure to them quite limited when possible. So the goal again is injectable initially and then maintenance on inhalant anesthetics. The one we'll talk about the most is isoflurane. That's what we use here in Canada. Sevoflurane you might see, and halothane we don't use anymore. Halothane no longer exists in the veterinary world in Canada. The properties of inhalant anesthetic is that it works upon the minimum alveolar concentration, so the MAC, and the MAC is the lowest concentration of a drug in alveoli in order to be effective. So the MAC equals the level of potency of that specific inhalant anesthetic. The lower the MAC, the less drug needed for the effect. So like I said before, it's not metabolized to any significant amount. We don't really know how it's metabolized. There's no analgesic effect, so there's nothing to help that animal go from totally unconscious to totally conscious. So that's really important when we're thinking about recovery of animals. So in some animals, like this bunny here on the right, and perhaps on this cat on the left, both of them, it looks like they're masking down, or they're using a chamber to get down. With that, in most cases, they're animals that are untouchable or difficult to restrain. So this is the instance where we haven't given a pre-medication, we haven't given an injectable anesthetic, we've only placed a mask with the inhalant anesthetic over their face, and they go into almost immediate general anesthesia. So then upon wake up, don't forget that there's nothing that is maintaining a level of sedation, there's nothing maintaining a level of pain management, they are just going from 0 to 60. So with waking up, if it's just a masked down patient, you can get a very stormy, very agitated recovery in these animals. In general, inhalant anesthetic is okay for kidneys, it's okay for liver, but it's a cardiac and respiratory depressant. So the gases, drugs include halothane, we don't use that. Isoflurane has a more rapid induction and less complications than halothane, has a characteristic scent, so that it's really nice for us because we know if our anesthetic machines are leaking, it has a bit of a pungent scent. Sevoflurane, we don't use that typically in Canada. It's more rapid induction and recovery with less complications than isoflurane. Desflurane, not commonly used, low potency. Nitrous oxide, used as a carrier to decrease the doses of other inhalants. You might use this, but you might not. We often don't in small animal medicine. And really important if you are using nitrous oxygen or nitrous oxide is that we want to give pure oxygen 5 to 10 minutes of 100% pure oxygen after anesthetic gases for the nitrous oxide. So once those anesthetic gases are discontinued, we want to give pure oxygen to prevent diffusion hypoxia. So essentially nitrous oxide, when it makes its way into the lungs, it dilutes any oxygen that's coming into the lungs. So for giving room air that's only 15 to 17% oxygen, the effects of nitrous oxide are going to further dilute that in the lungs, so we might only be giving like 5% oxygen. So then therefore we tend to give them 100% pure oxygen to ensure that we're at least giving a diluted form of pure oxygen and not just room air. That's specific to nitrous oxide. So for you guys, we are going to focus on isoflurane because all the others we simply don't use in veterinary medicine. So general inhalant anesthetics, their class is general anesthetic. Trade names, we're going to talk about isoflurane. Mode of action, we have no idea. Potential effects, they're quick acting, or positive effects, sorry, they're quick acting and they're quick to recovery. Side effects, unknown mechanism of action, they're respiratory depressant, they're cardiac depressant, and they do cause hypotension. So these animals on inhalant anesthesia, if you are having a hard time maintaining the blood pressure on a patient under anesthetic, under inhalant anesthetic, especially isoflurane, check your level of isoflurane. See if you can maintain them at a lower level, because that almost always increases their blood pressure. Okay, because isoflurane directly causes low blood pressure in our patients. So of course, administration, it's an inhalant. And then just a caution about general anesthetics. So this is one that goes back and forth. There was something put out, and I forgot to quote it. I don't have it written down. But it was a human health advisory for the use of isofluranes and other inhalant anesthetics. There is risk that these inhalant anesthetics can cause genetic mutations, cancer, renal disorders, hepatic disorders, nervous system disorders, reproductive disorders, and spontaneous abortion in people. So be really cautious. We advise, if you are pregnant, never to be involved in an anesthetic where there's any potential that anesthetic gases could escape. So that would be masking down a patient or using the anesthetic induction chamber. Always be very, very, very aware of that we don't always know the full effects of anesthetic agents. So the inhalant anesthetics, be extremely careful and cautious, protect yourself, and never be afraid to say no, especially if you're pregnant or if you have any other disorder that could be affected. All right, lastly, we'll talk about central nervous system stimulants. It's a short one. They're typically used to stimulate respiration or to reverse the depression of the central nervous system. They have the same effects as some toxins. So aside from the drugs that we actually administer to stimulate the central nervous system, there are toxins that have similar mechanisms of action. When given without a CNS depressant, they really produce a high level of stimulation. So examples of that, of course, are chocolate, which has theobromine that increases the norepinephrine release and decreases adenosine inhibitory effects. So that theobromine in chocolate creates a really high excitatory effect. So animals get really, really, really hyper. And caffeine has a very similar mechanism of action. So if we give central nervous system stimulants to animals who aren't undergoing central nervous system depression, then of course we're going to get this excitatory response. So this hyperactive, muscle tremor, crazy response. So they counteract inhibitory neurotransmitters, and the drugs include caffeine, theobromine, which is part of chocolate, and then of course when we're talking about medications that we administer, we're talking about theophylline and aminophylline. So doxapram, it affects the medulla of the brainstem, causes an increase in respiration. So we're often giving doxapram, which is called Dopram or Dopram V, to increase the rate and the depth of breath when an animal's under anesthetic. Or we'll give it to a newborn foal or newborn calf who's having difficulty breathing, or even a neonatal puppy. We can give Dopram to help stimulate that respiratory response. Because it stimulates many areas in the brain, there is caution with the potential for seizures when we're using doxapram. So if it's an epileptic patient or if it's a patient with a history of seizures, we want to avoid it most definitely. Typically, we titrate this to effect, so we're often giving it as an IV slow bolus, and we're titrating to effect until we start to see that respiration come back. So alpha-2 antagonists and opioid antagonists, some people classify them as central nervous stimulants, but in fact they're reversal agents. So they're antagonists for the medication that's causing the depression. So they are reversing the depression, but they're not truly creating a stimulation effect in the central nervous system. And that is it.